started, I want to welcome everybody to the Department of Medicine Grand Rounds today, March the 15th. And as part of our update series through our different subspecialties in internal medicine, we are going to hear from the Pulmonary Division today. It actually has a much longer official title than that, but I will leave it at the Pulmonary Division. And to introduce our two speakers today, I'm going to hand it off to Dr. David Guido, the Division Director of Pulmonary and Critical Care and a few other things medicine.
Well, thank you, Wendy. Welcome to Grand Rounds, everyone. I asked Wendy if it was all right to introduce Randy and Colin because I only have a couple more months as Division Director, and this may be my last chance to introduce two of my faculty to the department at large. In no particular order, we'll start with Randy Hunt. Randy is a native of South Carolina, trained in med peds, and then came to Emory for his fellowship. And in my 27 years, I can tell you Randy ranks in the top 1% of all the fellows we've ever had here. He joined the faculty with a special interest in cystic fibrosis. He also works in our transplant program, and he's the director of the adult cystic fibrosis program, which is one of the largest and, in my estimation, the best program in the United States. And it's really due to Randy's leadership. And an update, it lists him as an assistant professor of medicine, which he is technically, but this past week we learned of his promotion to associate professor, which is very exciting. Randy's going to be talking about cystic fibrosis, and then Colin Swenson will be joining him. Colin is a remarkable individual. He's a California kid who was running his own successful HR firm in Northern California in Silicon Valley, and felt that that just wasn't what he wanted to do with his life, and made a very brave decision to go to medical school. A significant drop in pay at that point, which he's only probably now just making up. We were so lucky to get him after his fellowship at Florida. He's on the faculty. He's our section chief at St. Joseph's. He's been here about 6 or 7 years, but I lose track because of the time. But Colin has risen to be section chief at St. Joe's. He runs a non-CF bronchiectasis and non-tuberculous mycobacteria clinic and program that is really a referral program from around the Southeast. And his expertise and leadership is reflected by the fact that our colleagues at Johns Hopkins invited him to their institution to teach them how to set up a similar program. So Randy and Colin are two of my favorite people in the faculty, and I'm so delighted that they're speaking today. So gentlemen, take it away.
Thank you, Dr. Guido and Dr. Armstrong. We're happy to be here. I think Dr. Swenson's going to get our PowerPoint pulled up here and we'll get started.
I sure will. Let me share my screen. And share.
Looks perfect.
Very good. All right, take it away, Randy.
Randy, you're on mute.
Randy, you're on mute.
Can you hear me now? Sorry, I was complicated with trying to run the PowerPoint. Okay, thanks. Sorry. Hopefully that'll be the. So these are the disclosures for myself and Dr. Swenson for this particular talk. In early 2000, I found myself in Boston at Mass General, where I was working as a pediatric volunteer. I mostly just hung out with kids and tried to keep their minds off of things. And that's where I met Mike. Mike was probably 16 at the time. I don't have a picture of him because times were different then. But Mike was there a lot, and he could talk smack. He was amazing at Mario Kart. And the reason I knew Mike so well is because he was a townie through and through, and he was at the hospital a lot. So we got to spend a lot of time together. And I didn't know why Mike was there. That's not the function of what I was doing at the time. But I could tell that he would come in and he'd be hooked up to various IVs. And after a while, he actually had a G tube, which I didn't know what it was, but he had some sort of feeding tube. And the one thing I could tell is that I could see that Mike was getting sicker over time. And his smack talk would be less frequent over the weeks and months that I would get to know him. Come to find out, a couple of years later after I had met him, Mike passed away. And that was my first experience, although I didn't know it at the time, with someone living with cystic fibrosis. And while Mike was incredibly unique, his experience of that disease was not at the time. So in the early 2000s, you could expect to live to about 20 or 25 with cystic fibrosis. This is Gavin here. Gavin, used with permission, is one of our patients here at the Emory and Children's Center. And Gavin's about the same age Mike would have been when I knew him in early 2000. Gavin's also amazing at computer games. But I think the difference is Gavin's future, I hope and believe very much, will be very different. And because of the amazing drug trials and therapeutic advancements we've had in cystic fibrosis, particularly in the last decade, I think we're much, much closer to a cure and really changing this disease, which was once defined as a life-limiting or early death disease, to more of a chronic illness. And so over the next few minutes, we're going to talk about that. And then in the broader context, what we're also learning about bronchiectasis, of which CF is only a very small part of. So one of the new trials and therapies that are available in CF, how that's affecting bronchiectasis as a whole, but also the other avenues in bronchiectasis that have to be trailblazed. So as many of you know, cystic fibrosis has been around for a long time. It's a congenital disease in which a person's born. It's a recessive disease. They get 2 copies from either parent. And we have, old nursery rhymes from the 1500s that describe bewitched children. Something to loosely is defined as woe to the mother whose child's brow tastes salty, for he is bewitched and soon must die. And we think very much that they were describing cystic fibrosis, which is a disease where they have excessively high sweat chloride and salty sweat. But you can actually, I think, Dr. Swenson, I've lost the ability to control the screen here. So if you don't mind, yeah, we'll just move forward. You can actually, epidemiological geneticists can trace CF way back into the Stone Age. So it's been around for tens and tens, if not hundreds of thousands of years. But in actuality, we only have modern medical terminology for cystic fibrosis as early as 1938. That's when we first sort of described it. So this is Dr. Dorothy Anderson. She was a hard-smoking pathologist who grew up not terribly far from my home in Asheville, North Carolina, and she found herself at Columbia University in her career, where she was a pathologist there. And one of her duties or responsibilities was to perform pathological autopsies on children. She very astutely observed that a subset of children who were previously diagnosed with celiac disease but died very early and did not seem to respond to the prevailing nutritional therapies at the time had this recurrent similarity between them, where they had this, what she described, cystic fibrosis of the pancreas. And when she found enough of these subset of individuals, she was able to publish a case series in the American Journal of Disease of Children. And she's subscribed as the one who first at least discovered cystic fibrosis as a separate clinical entity. And she would really spend the next 30 years of her career learning and advancing our knowledge about the CF. She, and along with a colleague in the next decade, would recognize that it was a genetic disease that was autosomal recessive, and that's kind of how it's hidden in humankind for so long. One of her great mentees and actually friend, another physician at Columbia University, Dr. Paul de Saint-Agnes, was a pediatric pulmonologist there and really took this cohort under his wing. He found them very interesting, and he was one of the early adopters of IV antibiotics and nutritional changes for these patients. And actually, in 1948, about a decade after they were described, he was the one who recognized that, like the old nursery rhyme said, that they had this excessively salty sweat. So there's this really bad heat wave that came through New York City, and many of his cohorts of individuals living with CF were getting severely dehydrated and having to be admitted to the hospital. And one of the things that he noticed, in addition to their high rates of dehydration, is that when they were doing rehydration, they would leave these very, very thick crystals of salt on their glasses of water as they were trying to rehydrate. And over the next decade, he would actually develop and refine the sweat chloride test, which remains one of the gold standards, or the gold standard, for diagnosing CF today. It wouldn't be until 30 years down the road that we would actually understand the protein defect. Dr. Desaigne-Agnes was on the road to that, but it wouldn't be until Rick Boucher and Mike Knowles at UNC would describe it in the 80s. And this is the problem in cystic fibrosis, this one little protein defect of the cystic fibrosis transmembrane conductance regulator. And traditionally, this has been described on epithelial cells. And while it is a transporter, it actually behaves as a channel. So essentially, it sits here on the apical surface of epithelial cells and it allows chloride to move in and out of cells. And when you have dysfunction of this, you get a lot of different problems in the person. So we already described how initially it was described as a pancreatic disease. And certainly we see that very early in life. But after they started to recognize these as different individuals and performed various nutritional therapies, what came very apparent early is that they developed a very significant obstructive pulmonary disease, and that would be the cause of most of their morbidity and mortality. So at the time in the 1930s and 40s, when they were treating this, it would be very unusual for someone living past the age of 5 with cystic fibrosis. And ultimately, it was either due to severe nutritional deficiency or, if they survived that, significant lung disease. But anywhere you have epithelial cells lining lumens, you can have dysfunction in CF. And so they get bad liver disease, luminal problems with digestion. All the men, almost to 100%, are infertile. They have a number of other problems. So significant comorbidities are associated with it, but it's really the lung disease that has limited their life expectancy for so long. And so much of our therapies have been geared towards that. So to understand why we've had some therapies, and particularly as we've moved into the modulator era in the last 10 years, it's helpful to know how CF sort of manifests as a pulmonary disease. So if you were to take a lumen of an airway and cut it longitudinally and look at it under microscopy, this is a caricature of what you would see. You'd see all these tightly packed epithelial cells with these hair-like projections on them, these cilia. And the cilia are there to provide some barrier defense and to protect you against particulate matter and other things you inhale. They're bathed in this fluid, which is called the airway surface fluid. And it's made of lots of things like glycoproteins and antibiotics, but it's primarily made of water, right? And the how hydrated that airway surface liquid is based, at least in humans, on your CFTR protein, allowing chloride and indirectly sodium to move in and out, salt, essentially. So in CF, when you have a dysfunctional CFTR, either because it's not there or the gate is shut, you get very, very dehydrated airway surface liquid. So the cilia can't do their job. You get this viscous, thick mucus, and then it becomes a harbinger for other bacteria, and you can get these recurrent infections. And Dr. Swenson will talk to you a little bit more about the vicious cycle hypothesis. But essentially, that's what occurs, ultimately leading to advanced lung disease from bronchiectasis. Is that coming up? Okay. Despite understanding that this was a separate disease entity, it would be 40 years later before we had a real breakthrough in cystic fibrosis understanding. While there were supportive care of this time and the age improved, the age of life expectancy improved, it wasn't until 1989 that we actually found the gene. So this is Dr. Soy, Collins, and Riordan, who were the 3 men who led the teams who would have found the gene that identified as the CFTR gene, which causes the protein defect. And this was a really big deal at the time. It made the front page of Science. The lay media thought that this was really, and a lot of the community as well, really were very hopeful that this was going to be the beginning of the end and that this would be a cured disease for the history books relatively soon, because everything comes from the gene defect, all the downstream consequences that we see. So the thought was, if we can precisely target a gene with gene therapy and correct it somehow, then everything beyond that should go away. Essentially, it should cure the disease. And a lot of attention, time, and money was then put directly into early gene therapy trials right after the gene was discovered. And it turns out gene therapy is actually pretty hard. And I say that tongue in cheek. Obviously, this panel knows that, and I'm sure the physicians and scientists knew it at the time, but from sort of like the lay perspective, that's not necessarily what was described. There was some very early in vitro success where CFTR, normal CFTR, could be transfected into cells. And this is Dr. Gerald McElveny and his partner, Ron Crystal, who is a physicist turned pulmonologist turned genetic therapist at NIH, who were doing some of the early in-human gene therapy trials for individuals with CF. Here's one of their patients. And then Dr. McElvaney is giving one of the viral vectors, carrying a normal CFTR into the right middle lobe. It turns out it was really difficult, though. There was a lot of discussion as to what the best vector would be for administration. In humans in vivo, there was very limited efficacy for transfection, and the longevity of transfection was very limited. And then there were significant concerns for adverse reactions. And then unrelated to CF, there was another unfortunate individual who was participating in a gene therapy trial at around the same time, Jesse Gelsinger, who unfortunately died as a direct result from that trial, and really caused the scientific community to not stop gene therapy in general, but to pull back from it. And so by the early 2000s, much of the scientific CF community had abandoned gene therapy as the next step forward, recognizing that probably some of the tools, at least at the time, were a little bit too rudimentary to make this a real viable cure. And so with that having gone down or seeming much more difficult than what was initially hoped, a lot of attention was then pointed towards some of the downstream consequences of CF. Like, what can we do to change infection or inflammatory rates? But it wouldn't be until 1993 that we would actually have the first FDA-approved CF-specific therapy, and that was Dornase alpha or DNase alpha. And over the next decade, there was a lot of attention and scientific research looking at some of these attenuators of these downstream consequences. And essentially, these are Band-Aids. They're very sophisticated Band-Aids, and they helped move and inch the average age further. But ultimately, they only were sort of attenuating things. They certainly were not a cure. So it wouldn't be, you would think that the next great breakthrough, which really happened in the early 2000s, would have come from some very sophisticated bioengineered, discrete medicinal development. But in fact, what it really came from was a scavenger hunt, a very sophisticated scavenger hunt, but nonetheless a scavenger hunt. So in the early 2000s, there was this startup company for drug development called Aurora, which was out of San Diego. And they had this really slick way of looking for different chemical compounds that might be drug or might have therapeutic effects through a high throughput process. And so the way they did this essentially is they would mine these huge libraries of chemical compounds, like tens and tens and tens of thousands of chemical compounds. And they would set it up in an automated process where they would have these cells, in this case, in the CF realm, they had these rat thyroid epithelial cells that were transfected with some sort of mutant CFTR, something that would cause CF in a human. And the cells also express some sort of fluorescence protein, in this case, a yellowfluorescence protein. And essentially what they would do, and I'm really simplifying this here, is they would essentially test these compounds either in single or in combinations by basically just putting them on these cells and then looking for fluorescent changes to see if that would trigger or see if there was fluorescent changes, it would potentially mean that there was triggering of CFTR activity, i.e. the mutant CFTR is actually working because of the test compound. And so they would do this, and they could do like 10,000 compounds or combinations a day. And when they found a potential target that looked like CFTR was being activated, they would then go through structural activity relationship medicinal chemistry to refine the target. And they were looking specifically for modulators, something that could make the protein that normally is mutated behave more normally. So okay, sorry. There's a little lag time for me. So to understand the different protein defects, it's helpful to understand the mutations. So I mentioned already that there's one gene defect in CF. There's lots of mutations for that. There's more than 2,000 actually. And there's a couple that are probably worth noting. So this class 2 mutation here, this is where the protein gets built. It actually gets made, but it's misfolded. So it gets stuck in the cell and it doesn't go where it's supposed to be, which is the apical surface. This is important because the delta F508 mutation, of which most of you probably have at least heard of, is very common in the human population. So about 90% of people in North America have at least one copy of this if they have CF. Another mutation that's important is this class 3 mutation. So this is where the protein gets made and it goes to where it's supposed to go. It's just the door is shut, the gate is closed, and these are gating mutations. And these are also important because a healthy percentage of individuals have this as well. This averages up, I mean, this equals up to more than 100 because you have 2 genes. So some people may have one class 2 and one class 3 mutation. So what they were looking for was a potentiator, something that could turn on CFTR. And hopefully, yeah, there you go. What they were looking for were these potentiators. So if you had a mutation where the protein would make it up to the cell surface, but the door is shut, you could potentially add a potentiator, which would just open the door up, hopefully. Now, if it was a different story, if the protein got stuck in the cell itself, for that, you would need to rescue the protein up to the cell surface before anything could work on it. And that's what they would call a corrector or a chaperone. And the first, despite, they essentially were looking for a needle in a haystack, but they could do this very, very quickly. So in a matter of about 8 years, they were able to find some pretty strong targets. And after a couple of years of in-human trials, we had our first FDA-approved CFTR protein modulator. And that really ushers us into the era of highly effective modulators. So the first one that was discovered was this VX770, which would later be called IVAC. It was specific for this one mutation, this G551D. And that was a class 3 mutation. And you'd remember that's where the protein makes it to the cell surface, but it's shut, the gate's shut. And so what IVAC potentially did, at least in vitro studies, is opened it up or allowed the door to open so chloride could enter or leave the cell. So this was then studied in humans, and this is the phase 3 trial data. They took about almost 250 individuals who had at least one copy of G551D, and they randomized to either get a sugar pill or this ivacaftor. The nice thing about this is it's not inhaled, it's not IV. This is just an oral pill that they took twice a day. And for those who were on ivacaftor, within 2 weeks, they repeated their lung function and they had a 10% increase in their FEV1, their forced expiratory volume, in 1 second, which is phenomenal. We have not seen numbers like this since the early days of IV antibiotic therapy for individuals with CF. And these patients were optimized on other therapies. So to have this significant increase that was sustained over time was quite impressive. And it was, and it's been shown out over time to be consistent even beyond that, year that they did the trials. It helped individuals gain weight. They had far fewer exacerbations, and it's fairly well tolerated. There was a few more rashes or upset stomach, headaches, and dizziness, but by and large, most people were able to continue study drug. It turns out that ivacaftor, which was our first potentiator, our first modulator, has been included in every modulator since. And so there's a couple of things that are true of all of them because ivacaftor is in it. The first is that there's a very, very small group of individuals who can have significant LFT elevations, about 1%. It's metabolized through the liver, and we have to watch for this carefully. But by and large, again, most people tolerate it well. There's some murine data that ivacaftor may be linked to congenital cataracts in ridiculously high doses that you don't give humans. But because it's there, we do monitor for it, though I've never personally seen it in a human. And then it's metabolized through the CYP3A system, as many drugs are. And so any sort of inducer or reductionist in that system, you have to be careful if you're using a concurrent medication that does that. This has been studied over the last 10 years, and there has been expansion of it down to 4 months now. And so it has been fairly well studied, well tolerated, and it really has showed a decline in lung dysfunction in patients with CF who have been on it consistently. The downside with it is that of everyone who has G551D, it was only about 4% of the population. So if you had it, it was great. This was a really effective therapy for you. And again, just a pill that you took, but it left a lot of people out. There were other modulators that have come along in the last decade. I mentioned them here because they're important milestones, or really more stepping stones, because they did advance modulator therapy for people who had delta F. Remember, 50% of people have 2 copies of delta F, and 90% of people have at least 1 copy. But these, unfortunately, were not super effective. They did show some mild modest improvements in lung function of about 2% to 3%, but it wasn't really what ivacaftor was for people who had class 3 mutations. It wasn't highly effective. Then in 2019, there was a significant breakthrough where they discovered, again, through this high throughput processing, 2 correctors when combined with a potentiator could specifically work for people who have just 1 copy of delta F. And again, there's a lag, so I'm not really certain where we're at. Let me back up. There we go. So elexacaftor and tezacaftor are correctors. Remember, the correctors help the protein make it to where it's supposed to go, and ivacaftor can then potentiate it and help the door open up. And this was initially discovered in vitro studies, and then there was a large phase 3 trial that was performed in humans who had just 1 copy. And this is the trial data. So this is about a little more than 400 individuals who had 1 copy of delta F. And you can see that they were split to either receive study drug or sugar pill, placebo. And after 2 weeks, there was a 14% increase in their FEV1. And again, these are phenomenal numbers. These are people who were already well optimized on therapy, and this is a function that they were getting above what they already had. And the first time point that they did was for 15 days, but in fact, patients in reality feel the effects within 12 to 24 hours. It's almost instantaneous. I put here that there was sweat chloride significant changes as well. I think this is important for 2 reasons. One is it shows you that this drug is working where you'd expect it to. It's working on the chloride channel. It's allowing it to work. And the decrease is quite significant. So for many people, their sweat chloride levels dropped below what would be considered the diagnostic threshold for CF. Didn't make it normal, but it dropped it below what would be the diagnostic threshold. Most had significant improvements in exacerbations. And the real key here is that it was highly effective, and it expanded highly effective modulator therapy to 90% of the population. And a lot's changed just in that last year. This was FDA approved at the very end of 2019. In 2020, live births to females living with CF jumped from around 200 to more than 600. There were only half as many lung transplants, with only 91 lung transplants being needed in individuals with CF in 2020. There have been significant improvements even in individuals who have advanced lung disease. So for individuals who already have lived for 20, 30 years and have significant lung disease, do they do as well with these modulators? And again, this is not a cure. It won't make lungs normal, but it can significantly improve things. So this was about 250 patients out of France, all who had lung function under 40%. And more than half of them were able to come off of long-term oxygen therapy. There were significant improvements in non-invasive therapy and supplemental feeding. And importantly, of the 53 that were listed for lung transplant at the time, 48 were able to come off of lung transplant listing. So we're still really new in terms of these modulators. I'm sure some of you have seen direct effects with less exacerbations and less admissions. And so where do we go from here into the future? Again, sorry about the lag. When I first thought about CF, if you asked me what a person looked like or sort of conjured up a person in 2000 when I was, a medical student, I would think of a young child who, was sort of poorly ill. And that's not what CF is now. There we go. Really, it's a multifaceted disease where more than 57% of the individuals are adults, and that improves by 1 or 2% every year. 15% of the population is non-Caucasian, and importantly, 10% still don't have modulator therapy, and no one's leaving that percent behind. There's great interest in sort of the next round of modulators and now gene therapy. And because of modulators, the conditional survival has both average survival and conditional survival have significantly improved. Median survival is predicted to be almost 50 now, with conditional survival being over 60 if you live to 35. So what's the next steps? Well, probably back to gene therapy, especially with the advent of CRISPR-Cas. There's a lot of great interest in looking at CRISPR-Cas, RNA, and gene therapy to find an alternative for these last 10% of individuals who don't have a protein that's available for modulation. And CF remains uncured, but substantially improved in terms of therapeutics from from what it was 85 years ago when we first, put a name to it. And it really has helped pave some ways for bronchiectasis as well. But bronchiectasis is such a larger umbrella than what CF is. And there's a lot in bronchiectasis, that a trailblazing that has to continue. And Dr. Swenson is going to take us through that.
So, the prior slide shows, sort of an Atlanta highway, and if CF research and development is now a multi-lane highway, what about non-CF bronchiectasis? And I think that this picture really sort of summarizes where we are. We're still searching for the trail in the woods, but we're definitely moving forward. So I always like to start this talk by just sort of backing up a little bit to talk about what is bronchiectasis. And there actually is an NHLBI definition, and that is the permanent enlargement or dilation of the lower airways. And so classically, you see this signet sign, which, and I'll show you what that is. It's that little ring sign, and it's where the bronchoarterial ratio is greater than 1. There are some caveats that we see that you can see radiographically, particularly in the elderly who may have airway remodeling over time and denudation of the respiratory epithelium. Also in patients who are acclimated to very high altitudes. You also have to be aware of CAT scan slices just proximal to the bronchial branching points where the accompanying artery has already branched. That can give you a false positive for bronchiectasis. And I like this slice because it shows you a couple of different representative images of bronchiectasis. The C over on your right is the signet sign. Over at A, you see sort of a cystic morphology or a terminus, a bronchiole that terminates in a cyst. And then B shows you sort of a smooth cylindrical type of bronchiectasis. And this picture sort of teases that out in a little bit more detail. It starts with cylindrical bronchiectasis. There are sort of these morphological subtypes ranging from the mildest, which is the cylindrical, all the way to the cystic, or sometimes referred to as saccular, which is much more severe. In this explanted lung right here, in a patient with non-CF bronchiectasis, you can see that there are areas of both severe cystic disease as well as a little bit more cylindrical and varicoid morphology as well in the upper lobes. These are CT slices from the same patient in my clinic with Cartagener's syndrome, where there's also dextrocardia. And you can see that there's pretty severe cystic bronchiectasis in the lower lobes bilaterally, as well as sort of areas of a little bit more varicoid morphology. And so what Randy was talking about earlier is the model of pathogenesis that's described by Cole. And that's called the vicious cycle model of bronchiectasis, where infection leads to neutrophilic inflammation, which leads to airway remodeling, which is the bronchiectasis, which leads to abnormal mucus clearance, which leads to more infection, and around it goes until you end up with the different morphologies we just went over. This is really still a valuable model, but we can fill in some further detail, such as the neutrophilic inflammation. We know now that elastase slows cilia. It decreases fractional excretion of nitric oxide, which causes impairment, immune impairment at the lumen level. It also increases mucus hypersecretion, which leads, of course, to the airway remodeling we talk about. Abnormal mucus clearance, which is a direct result of the airway destruction and distortion, results in altered microbiome. And that further plays a role in neutrophilic inflammation and airway remodeling. The end result, of course, is that you get enlargement of the diameter of the bronchus with increased mucus production, denudation of the cilia, as well as the perciliary hydration layer that Randy just went over, and of course, destruction of the bronchial wall. So what about treatment? Before we get too far into treatment, just a word about epidemiology. Non-CF bronchiectasis is technically not a rare disease. It affects almost 500,000 adults in the United States. And it's important to note that the incidence is increasing every year. By some estimates, almost 10% based on CMS data. This tends to be a disease of the elderly, as you can see below in the chart, with those over the age of 75 disproportionately affected. It tends to, although I should mention as a caveat that this disease is being diagnosed in younger patients with more mild disease, and that's partially as a result of better imaging modalities and more use of high-resolution CAT scans. The prevalence is highest amongst women and people of Asian and European ancestry. And it should also be noted that there is increased mortality with this disease entity, 10 to 15% in most series. Part of the challenge in defining treatment modalities is the sheer heterogeneity of the condition. Whereas in cystic fibrosis, you have a very defined pathway that leads to the airway remodeling. In non-CF bronchiectasis, the etiologies can be varied, as we'll see. So a careful patient history can give us clues to the etiology, particularly recurrent airway infections, if the patient has concomitant sinusitis. If there's a history of infertility, that can certainly point to cystic CFTR mutations, as well as ciliary problems, history of difficult to control asthma, familial bronchiectasis, and of course, family history of CF and autoimmune symptoms as well. Also history of inflammatory bowel disease, HIV infection, inhalation injuries, childhood infections, so sequelae of those infections, as well as sort of chronic problems that we often encounter in the outpatient settings, such as gastroesophageal reflux disease and other aspiration syndromes. This series of about 1,200, almost 1,300 patients with non-CF bronchiectasis who had undergone a whole battery of testing to try to discover the etiology shows us, interestingly, that up to half of cases, particularly in females, is idiopathic. Despite a battery of tests, we're still not able to define what the cause of bronchiectasis is. You can see the next most common form of non-CF bronchiectasis is post-infective, and that of course makes sense. Then there are a whole host of other conditions that can lead to bronchiectasis, including connective tissue diseases, immunodeficiencies, including hypogammaglobulinemia, asthma and ABPA, and so forth and so on. So we've made the diagnosis of bronchiectasis, but what's causing it and how do we move forward with treating it? And that really is the branching point of where we are now. There are radiographic clues that we can use on high-resolution CAT scan to determine, or at least get an idea of etiologies. For instance, if the bronchiectasis is primarily confined to the upper lobes, one would think about post-tuberculosis bronchiectasis, which is something we encounter in clinic quite frequently, sarcoidosis, cystic fibrosis, and also radiation fibrosis, which tends to affect the upper lobes. What about the lower lobes? That can indicate chronic aspiration as the etiology of bronchiectasis, as well as ciliary dyskinesia, immune deficiencies, and inflammatory bowel disease, particularly ulcerative colitis. What about the right middle lobe and the lingula? That's almost always a sign that atypical infection, chronic atypical infection, particularly non-tuberculous mycobacterial lung infection, could be the cause. What about central? That's something we tend to see with ABPA, or allergic bronchopulmonary aspergillosis, which tends to affect the central lung zones and can be quite severe, and also different inhalation injuries. What about local or lobar bronchiectasis? This is typically the patient with post-infective or post-pneumonia bronchiectasis, or also post-obstructive, for instance, in our patients with bronchial lung cancer. In those with very diffuse bronchiectasis that sort of affects all 5 lobes, we do tend to think about cystic fibrosis, particularly CFTR mutations, where someone is heterozygous and carries one pathogenic copy. Ciliary dyskinesia syndrome, alpha-1 antitrypsin deficiency can also cause a diffuse morphology, and hypogammaglobulinemia. We know from Dr. Hunt's presentation that CF results in bronchiectasis, but we are increasingly aware that CFTR heterozygosity, or a carrier state, is associated with bronchiectasis. A clue to this would be persistent isolation of Staph aureus from sputum culture. Certain autoimmune diseases are associated with non-CF bronchiectasis, most commonly rheumatoid arthritis and Sjogren's syndrome. We're also increasingly understanding the role of ciliary abnormalities in the development of non-CF bronchiectasis. And this can range anywhere from primary ciliary dyskinesia to cartaginors to minor motion abnormalities. Connective tissue diseases such as Muir-Kuhn syndrome or tracheobronchiomegaly, where you just get a very enlarged trachea and right and left mainstem that are highly collapsible. That can result in more distal bronchiectasis. Marfan's disease and cartilage deficiency, or the so-called Williams-Campbell syndrome, can also result in it. Immune deficiencies, as we've talked about, including primary immune deficiency, HIV infection, and alpha-1 antitrypsin deficiency. Other etiologies that one would want to consider are the hypersensitivities, particularly allergic bronchopulmonary mycosis or aspergillosis, which we see in our patients with severe persistent asthma. Patients with inflammatory bowel disease, particularly ulcerative colitis, they can be at risk of developing lower lobe predominant bronchiectasis. Injuries, pneumonia, whether it be pneumonia, infectious, TB, NTM, or childhood infections, GERD or chronic aspiration syndromes, smoke inhalation, radiation injury, and the like, and certain malignancies are also associated with it. So how do we go about testing for the etiology? Both the British Thoracic Society and the European Respiratory Society published guidelines for etiologic testing for non-CF bronchiectasis. But unfortunately, we've not yet done the same here in the US. Most of the centers that treat this with regularity, however, typically do the tests that are on this slide. The first one, of course, is getting a sputum culture. And we would culture typically for both typical and atypical bacterial organisms, as well as fungus. And so I like this slide, not because I am pro-gun at all, because there is no such thing as a silver bullet when it comes to treating non-CF bronchiectasis. It really requires a multimodal approach, as we're about to go over. So the management of non-CF bronchiectasis, once you've made that diagnosis through the high-resolution CAT scan of the chest, one would want to get a clinical history, as we talked about, and lab evaluation to identify etiology. If you're able to identify an underlying etiology, particularly if it's something correctable, such as alpha-1 antitrypsin or immune hypogammaglobulinemia, that's something we could potentially treat. On all of these patients, virtually all these patients, we initiate airway clearance therapy, which we will talk about in later slides. A sputum culture, all roads lead to sputum culture when the diagnosis is made. These patients oftentimes are deconditioned. They may have nutritional deficiencies. And so exercise program or pulmonary rehabilitation, if the patient qualifies, is a modality that we would want to pursue. And lastly, if the patient is just always on antibiotics, hospitalized with recurrent bacterial exacerbations, one might consider chronic macrolide therapy with azithromycin thrice weekly if that patient is a frequent exacerbator. So I highlight airway clearance because it's near and dear to my heart, and we're going to get into that in further slides. So if the sputum culture isolates just normal flora, this is a patient that we would observe. If it's a non-pseudomonal isolate, we would typically target antibiotics toward that organism. If it is Pseudomonas, we know that chronic pseudomonal colonization can result in frequent exacerbations and hospitalizations and increased mortality. So typically we undertake an eradication strategy. We at least attempt it initially. And if we're not able to eradicate it, then we would embark on a suppressive regimen with chronic nebulized antibiotics. And if the patient isolates NTM, which is a whole other talk that I'm happy to give at some point, you would want to monitor future cultures for that same organism. If you have 2 or more that are positive for the NTM organism and the patient is symptomatic, you would consider treatment. In these patients, you would want to avoid macrolide monotherapy or chronic macrolide use. So I've simplified that algorithm into what I call the four pillars of bronchiectasis treatment. And we're going to go over what those are right now. The first pillar is mucoactive agents. And there are really 3 categories of mucoactive agent. The first one is our mucolytics. These include Dornase alpha, as Randy went over, and acetylcysteine. These cleave disulfide bonds and degrade mucin polymers. They really liquefy the mucus very, very well. And for that reason, it's not recommended in non-CF bronchiectasis. There are a number of reasons for that, or theories that have been postulated, including the heterogeneity of the condition and the distribution of the bronchiectasis. But the clinical trials did lead to an increase in exacerbations and hospitalizations. And so we don't typically use mucolytics in this patient population. The second are hyperosmolar agents. These are the mainstay of therapy for bronchiectasis treatment, and that's usually hypertonic sodium chloride, anywhere between 3 and 7% through a nebulizer. These do cleave hydrogen bonds, but they really hydrate the perciliary layer very well, and they improve the viscoelasticity profile so that the patient can actually bring up the sputum, mobilize it. They also release histamine and acetylcholine, which increase ciliary beat frequency, which is so often impaired in this patient population. And lastly, there are the mucokinetic agents. These are your SABAs, your LABAs, your methylxanthines. Usually it's what we prescribe as the albuterol and levoalbuterol in clinic. It's important to note that we do not prescribe anticholinergic agents for these patients, such as ipratropium or tiotropium, because it can have the opposite effect. Our pillar 2 are the airway clearance techniques, and this is really a multimodality treatment. We're talking about mostly the devices, techniques, and positioning that can help clear mucus from the lower airways. And this can include traditional chest physiotherapy and postural drainage. It can also include breathing exercises such as autogenic drainage and active cycle breathing. Also different devices that you may have seen both in the inpatient and outpatient settings, such as the acapella, the flutter valve, or the aerobica OPEC device. And then there's, of course, high frequency chest wall oscillation, otherwise known as the best treatment. And so this is just a diagram showing, traditional chest physiotherapy, which used to be used very frequently in the CF population and the post-tuberculosis patient population, but we're increasingly using it now if the patient is so motivated to learn. And then, of course, there is the high-frequency chest wall oscillators. This is a diagram of the VEST system. We also have portable devices such as the flutter valve, the acapella, and the aerobica, which you can see here. And there are also breathing techniques that we talked about, such as active cycle breathing, autogenic drainage, and huff-cough technique that the patients can do themselves in order to mobilize secretions. The third pillar is exercise. We know from multiple trials the importance of regular exercise on bronchiectasis outcomes, and that's both for the CF population as well as the non-CF bronchiectasis population. Regular exercise increases the time to first exacerbation and also reduces the frequency overall. So this leads us back to Cole's vicious cycle hypothesis. So airway destruction and distortion, which is the bronchiectasis, unfortunately, there's very little that we can do about that at this time, apart from surgery, apart from an operation to remove the affected area if it's very localized. But abnormal mucus clearance we've addressed in pillars 1, 2, and 3. Which leads us to our fourth pillar, which is antibiotics, which play obviously a very key role during exacerbations. So the most common non-CF bronchiectasis pathogens differ from cystic fibrosis pathogens in that Pseudomonas aeruginosa is typically what we isolate in clinic, especially in more advanced or later disease. We also do see Staph aureus, Moraxella, and H. influenza. We do know from clinical trials that Pseudomonas aeruginosa colonization does result in increased frequency of exacerbation, as well as decreased lung function. And so that's the reason we attempt eradication at initial colonization. Exacerbation treatments, these are patients who either end up in the hospital or are treated on an outpatient basis. We base this on sputum culture data that we've collected. If the patient isolates Pseudomonas, we typically do a 2-week course of Pseudomonal antibiotic. Inhaled antibiotics or nebulized antibiotics, such as the aminoglycosides, particularly tobramycin, have been shown to decrease exacerbation frequency and improve quality of life measures in patients with non-CF bronchiectasis. The regimen, however, is completely extrapolated from the CF literature. So thanks, Randy. And what about macrolides? They are technically an antibiotic, as we know, but macrolides, particularly azithromycin, taken on a chronic basis, have been shown to be very effective in the treatment of both CF and non-CF bronchiectasis. And that's because they do exert immunomodulatory effects on the host inflammatory response. And it does that in a way that it does not cause immunosuppression. We know that it does a great job of inhibiting biofilm production and also moderates leukocyte recruitment and function. There are a number of randomized clinical trials, fairly large, that have shown effectiveness. Probably the biggest caveat would be that NTM infection, particularly chronic colonization, must be excluded before initiating this treatment. So this leads us back to Cole's hypothesis. We've now talked about bacterial colonization, or pillar 4. So what about neutrophilic inflammation, which we know is sort of the hallmark of this disease? So in patients with bronchiectasis, we know that they have elevated neutrophils in their sputum. We know that neutrophil serine proteases are increased in the sputum at baseline and further increased during exacerbations. Now, dipeptidyl peptidases activate the neutrophil serine proteases, and DPP1 in particular controls activation of those NSPs and results in increased neutrophil elastase. So really, DPP1 then would make a very tempting therapeutic target. And in fact, there are a number of clinical trials right now looking at that specific pathway. So targeting DPP1, the largest trial we have to date is the Bronchiectasis trial. And this, in fact, showed that it was very favorable. The largest trial was for this drug, and it significantly decreased sputum neutrophil elastase concentrations, and even more important, significantly reduced the number of exacerbations by patients randomized to the Bronchiectasis arm. There was about a 40% reduction in exacerbations between the patients on Bronchiectasis and those on placebo. So this looks to be a very exciting tool in our arsenal. So in summary, high-resolution CAT scan CT is diagnostic and can also suggest etiology of the bronchiectasis. Try to determine etiology if possible, because we can potentially treat it. Airway clearance techniques are the initial and ongoing treatment for non-CF bronchiectasis. Macrolide therapy is an effective tool, but there is the qualification of ruling out NTM infection. Antibiotics should be used judiciously, and surgery for localized disease and transplant evaluation can certainly be considered for more advanced disease. And lastly, emerging therapeutics targeting the inflammatory mediators are on the horizon. Thank you very much for listening to our talk today, and we're happy to take questions.
Well, thank you, Randy and Colin. Anyone who has any questions can please place them in the chat, and we'll try to get to them in the remaining few minutes. While we're waiting for that, Randy, can you give me and us an idea of, with these incredible drugs now, does that obviate the need for the airway clearance strategies that Colin and you have talked about? Are there individuals who can just throw away their hypertonic saline, or do they have to continue at least some reduced level of airway clearance in addition to the drugs?
Right. It's an excellent question, and one that we're trying to answer right now. And it's probably everything you just said. I think there's a subset of people who clearly still need airway clearance and these other medications, because even though this certainly attenuates their disease, it doesn't take it back to normal. And they probably already have a certain amount of bronchiectasis that is just not going to get better. But for individuals who are slightly healthier, what they have, many of them have come off of some of these medications on their own. They describe it in clinic as if they don't have CF, or that's how they feel. And so there's two trials right now, both the Simplify and the Promise study, which is a multi-site trial. Emory here is also a recruiter trying to answer that question. If we take individuals off in a very organized manner some of these therapies that they've been chronically on, do we see a decrement in their lung function or other things? So I'll be able to answer that better in 2 or 3 years. But right now, yes, there are some people coming off some of these therapies, both with and without the guidance of whomever they're working with from a physician standpoint.
And there was a question in the chat, Randy, which you touched on a little bit in your talk. It says, in the past, HIV care changed from managing complications to disease suppression and chronic care. How will this look in CF?
Right, I agree. Yeah, Mikkel is I wasn't practicing medicine in the 90s, obviously, but I really kind of think, people can correct me, that I think this is what like heart therapy would have been like in the 90s for HIV. For many people, CF is becoming more of a chronic illness. And it'll be very interesting to see what geriatric medicine is for our patients with CF. But there's still that 10% of population that don't have modulators, and their disease progression is as it always has been. So there's still a lot to be done and care that needs to be done.
And Colin, since we live in the American Southeast in Georgia, how about Lady Windermere syndrome? Is it really just chronic cough suppression that leads to mycobacterium infection, or are there any new insights into that interesting subset of, as you know, the asthenic woman in her 70s who comes in with typically MAC and bronchiectasis?
Yeah, so initially when it was described, it was described as Lady Windermere syndrome, which is actually a little bit of a misnomer. Lady Windermere, Oscar Wilde's famous play. She was actually a young woman. She was proper, but she was young and did not have a chronic cough. But yes, this phenotype, it's called the nodular bronchiectatic phenotype. These women tend to be women, but we definitely see men as well. We do not think it's due to suppression of chronic cough. We think that it's probably, like a lot of other things, heterogeneous, but in some series, up to 60%, almost 2/3 of patients have been identified with a minor CFTR mutation. So we think that this might actually, be a manifestation of CFTR related disease, although more work needs to be done on that. We've also found that these patients tend to have suppressed or decreased fractional excretion of nitric oxide. And so we think that there's immune compromise at the ciliary level that we're just now beginning to understand. But
all right,
David, you're correct in that the Southeast is sort of Grand Central for a lot of these infections.
Well, we're past the hour. Really appreciate both of you, and I'm very proud both of you. A fantastic presentation, and want to wish everyone a happy rest of their day, and we'll look forward to seeing everyone next week. Thanks, Randy, and thanks, Colin.
Thank you. Thanks so much.